TopMedTalk.
Well, hello and welcome to TopMedTalk. We are here at Anesthesiology 2024, the annual meeting of the American Society of Anesthesiologists. Now, I'm Desiree Chappell, your host today and co-editor-in-chief of TopMedTalk, and I'm joined by my co-host, co-editor-in-chief, Professor Mike Grocott. Good morning, Mike.
Morning, Desiree. Great to be here with some excellent guests this morning.
Yes. We're going to dive in here in just one second and get this weekend started. But we wanted to say, first of all, thank you to the ASA for supporting us to be here this year in the exhibit hall with this gorgeous booth right next to center stage, right in the mix and center of it all. So thank you very much to the ASA for that, as well as all of our sponsors, Edwards Life Sciences, GE Healthcare, and Medtronic. They are able to keep TopMedTalk free and open to the entire world. No one ever has to pay for TopMedTalk. And it really is a leading platform in perioperative education and really disseminating a lot of information around our space in anesthesia and perioperative medicine. So thank you to them. But it is with immense pleasure and honor that I introduce our next guest, Dr. Wael Saasouh, who is a colleague of mine from NorthStar Anesthesia. He's the Regional Director of Research for NorthStar. Wael, thanks so much for joining us.
Good morning. Thank you for having me again. I'm Wael Saasouh. I'm a Regional Director of Research for NorthStar Anesthesia, and I'm an anesthesiologist up in Michigan. Happy to be here.
Yeah, that's great. So Wael, for our listeners, tell us a little bit more about what you do, this Regional Director of Research that's kind of different for a large non-academic type anesthesia group.
I come from an academic background, and that's the structure I trained under. Joining NorthStar was a transition in my career. But when I first joined, they had this immense interest in pursuing quality, education, research, academics, and all that. So we started creating the structure in a place where it didn't exist. Definitely very exciting, very rewarding, a lot of headaches.
It's been a journey.
It's a journey. But I'm very happy that we did this, because now we have a more or less robust infrastructure for doing research. And now we have a lot of opportunities for clinicians who aren't routinely doing research to be involved in academics, to be involved in meetings such as this one, posters, presentations, abstracts, manuscripts. We have a lot of contact with industry, with our funding partners. So it's become something interesting.
Yeah, absolutely.
Tell us the sort of themes that you're picking off in this quest to improve quality.
One of the major things that we've done is hemodynamics and hemodynamic instability in general. And we've published some papers on IOH and on monitoring of vitals.
And forgive me, but IOH, just very uninitiated.
Intraoperative
No
hypotension.
letters.
Yeah.
Okay, so hemodynamic instability during anesthesia.
Exactly. Yeah. And I have a lot of focus on medical informatics, on devices, newer devices, technologies, things of the sort. And we have a mixed bag of projects that we do with our trainees as well.
Yeah. Wael and I work very closely on this. It's separate in NorthStar, where we're kind of doing a lot more quality improvement projects and things like that. And then Wael, you're associated with Wayne State, correct?
I am.
And so you kind of do your thing on the bigger research projects there.
So for clinical research at my local institution, I'm affiliated with Wayne State University and Michigan State University. So I go through the IRB of Wayne State to do the clinical research that I do locally. And then when it comes to NorthStar, we're at the stage where we're doing quality improvement and sort of a bird's eye look at how things are happening. And then we're hoping to evolve with time.
It's wonderful because we're able to partner with our hospital teams where we practice, and really it's a collaborative approach to doing this quality improvement that we are, which is a lot of fun.
Now, you've talked to us before about some work I think you started a few years ago with USAP. How's that going?
Correct. That has gone very wonderfully, actually. It was one of the rare collaborations that I've been part of, where two major anesthesia provider institutions, that neither one of which is strictly academic, came together with an industry partner, and then we got an immense amount of data, and then we talked about intraoperative hypotension and risk factors, and we did this big observational cohort, and we came out with two large papers, and the third one's on the way, and I think it shed some light on some of the preventable causes of IOH, and we tried to focus a little bit more on the role of a clinician in that it's not just patient factors, and there is some tendency to get intraoperative hypertension in cases where you would think it wouldn't exist. So healthier patients, ambulatory surgery centers, we still get the same incidence of intraop hypertension that is reported across the board, which is close to 30%. That was a surprising, but also it was an eye-opening discussion that we had. And now we're trying to focus on how we can try to mitigate that.
Yeah, and I think you touched on it. What we found was the most significant impact on the amount of IOH was not the patient risk factors.
if you adjust for everything else,
yes,
the clinician is a big driver of this.
yeah,
So this is similar to the data that came from California looking at fluid administration in major surgeries. I think cohort of maybe nearly 30,000 patients,
Yep.
which again suggested that the biggest determinant of fluid administered was, I think, first the attending anesthesiologist's identity, and then second the attending surgeon's identity.
Who thought we could control these things?
Nothing to do with the patient.
No,
Which is extraordinary.
Right. It's easy to blame external factors, and not for lack of trying. It's just we take care of so many things on a daily basis that we see a patient who we think is going to be difficult, quote unquote, or difficult to manage, and then everything gets fine. It's understandable that this patient has a complication. Sometimes we have a little more control over this than we admit, and I think it's time to start looking at those things and try to optimize what we do. And then if complications happen due to other reasons, then we have other treatment modalities and other algorithms for that.
But we're really not as consistent in our practice as we would like to believe.
for sure. And I think that's one of the biggest learning points for us. And as an organization, and even within USAP, we've had these discussions with, of course, Rick Dutton, is that real standardization of our approach to hemodynamic management and trying to figure out and key into when we really need to focus on bringing everyone together and have that consistent level of care. Whether it's protocolized, you still are individualizing, but you have some guardrails around.
Right. And it's hardly difficult these days. There's a lot of technology that's in place. There's a lot of technology that's on the market and that's ready to be used, and it's accessible, that can help with all the other things that we do so that we can start focusing on things that matter on a higher level.
Yeah.
And I think this is one field we can make an impact in.
So where have you gone with the quality improvement side of this? Where have you gone with that?
Basically, the impetus to try to figure out how to better standardize our care. Obviously, it's a very long process, and it's not going to happen overnight, but we at least started the discussions within our institutions and across with our partners. I think there's more to come on that front.
How do the individual providers, so we talked about this profound variation, the identity of the provider being the principal determinant thereof, how do the individual providers respond to that? Are they comfortable with that?
I think for the most part, providers have this notion of, we have a certain amount of complications that happen. We know some of it is preventable, but I don't think there's a lot of insight into the actual numbers or how much of a problem this actually is. So when you tell an average provider that a third of your patients are getting hypotensive, most people don't think so. And when we're in the moment in the operating room and we're dealing with a low blood pressure, we don't always register that this is preventable, because sometimes we're expecting a low blood pressure event because we just induced or this patient just lost some blood. I think once we start giving them a larger view picture of how the trends look like, how the entire group looks like, how do we compare, or how do you as individual compare to the rest, and where should our benchmark be, then they will start paying more attention to it. And one thing I've noticed, since we've started working on this, I look at my own patients. It happens more frequently than I'd like to admit. And now I'm hyper-focused. If I'm with a resident and I see a blood pressure dipping down, be careful, this is going to drop even more. Where in the past, we would just brush it off as something that is expected.
I mean, different context, but this reminds me of the observation that 9 out of 10 drivers believe they're better than average.
Yeah.
Oh, yeah. I would say 11 out of 10 drivers.
11 out of 10 anesthesiologists.
Yeah.
This has been a really evolving process and the evolution and a journey for us within NorthStar. I think once we kind of got that initial data set to say, we actually do have hypotension, we are experiencing that in community practices, that was the focus. We started to look at the data a little more closely, and that's the paper that we're working on now, where we did a lasagna plot, which is really interesting. I'm sure hopefully once it gets published, you can see it. But it looked at spine cases, so we pulled spine out specifically, because it's a lot of personally where I work, and we'll talk about that in a second. But we looked at spine, and then we broke it down into where the hypotension was occurring, correct?
Right. And we looked at certain aspects of the surgery where we think hypotension is more prevalent. So we looked at post-induction hypotension. We looked at what we call surgical hypotension, which is during the surgery phase. And we started seeing some patterns, and we started looking at risk factors of where does the hypotension occur more and what is it related to. And it's interesting to see that lasagna plot basically plots every single surgery on the same graph as a timeline. And then you start seeing we have a lot more concentration of red here, and then after the surgery, and then sometime towards the end, for example.
Yeah.
And then now you can start seeing groups of patients having hypertension at the same time, and then you isolate those and you get the risk factors for them. So we focused on hip and knee surgeries just because they were a little more predictable, the way the surgery happens. And I thought it was interesting. It's still observational, we're still not changing practice. We're trying to isolate the risk factors where these patients will get hypotensive, but who is more at risk and what are the risk factors? And we know it's not just the patient is sick. We know there's a lot of things that go into it as well.
Yeah. So what we did after this was when we looked at the spine data, again, I'm very interested in that. We work at one of our facilities with Leatherman Spine Institute, which is one of the largest in the country, and started talking to the president there and Dr. Steve Glassman and Dr. Jeffrey Gum about this concept of intraoperative hypotension and the impact of outcomes, because that's where we know that there is an obvious impact. And most of the time in the anesthesia world, we were talking a lot more about acute kidney injury and MINS, which is where we've seen a lot of the research come and mortality and things like that. And so when we started talking to him, he was super interested in surgical site infection.
Right.
And so he's like, if we could kind of crack that nut, that would be really interesting. And so he needed a little convincing that this was actually going to impact his patients. And so he went through kind of a quick little survey of a large number of his cases, and he knew there was an association with diabetes. So he looked at diabetes and the impact on SSI, and then he compared that to the impact of intraoperative hypotension. And when we say that, it is defined as a mean less than 65 for greater than 15 minutes. He actually found a stronger association with IOH than he did on diabetes.
Interesting. Were they additive, do you know? Could you kind of expect they might be?
Yeah, I don't know. I think that he actually looked at that closely. This was
would
just
make sense.
it would be. But it was a very high level just to see if this was worth it to him.
Right.
So look.
So he's convinced.
So he was completely
Spoiler,
convinced.
it is.
Yes. And spoiler alert. So we've had 2 papers published actually from this. So the first paper is more around the impact of intraoperative hypotension on specific outcomes, right?
It's interesting that we looked at spine cases specifically.
Yeah.
Because just like we were talking about hip and knee, it's a more or less a standardized surgery. And we looked at the multi-level and the complex ones where definitely they're more at risk of developing this hypotension. And we looked at surgical site infections, acute kidney injury, and
GI complications,
nausea, vomiting, all
nausea,
of those
vomiting,
things,
NG tube for ileus.
we're presenting this on Monday as
Yeah.
well. If you're around, come by. But this is where the results of all these collaborations come to fruition. Because first we laid the foundation of let's start collaborating, let's start collecting, let's know what we have to start with. And now we're starting to look at impact and we're starting to look at intervention and how can we start changing those outcomes for the patients, because ultimately all we're trying to do is to improve patient outcomes. But I think this has been a very fruitful collaboration with Leatherman Spine, and I'm looking forward to more.
Yeah. Well, and then we've had a second paper. We started looking at the impact of intervention, and really it is a quality improvement project because it was really a changing of team anesthesia and compliance with an pretty much existing GDT protocol.
Right.
That we had
GDT.
sent. Goal-directed therapy and goal-directed hemodynamic management, really following a strict protocol and seeing the impact on outcomes. And, go look at the paper. We'll have a link to that. A bit of a spoiler alert. We actually were able to improve outcomes and the amount of IOH by doing this standardized approach and really impacting outcomes for our patients. So it's a very small pilot.
It is, but it goes to show that we have control over some of these things at least, and we can limit the damage that's happening to patients by just being a little more insightful about what happens.
Just a little detail on that, because this is obviously, it's quite a tortured literature with a lot of controversy. What was your intervention? What were your goals? And then what were you using to achieve those goals?
We are using one of the monitors from Edwards where we look at hypertension prediction. So they have an AI algorithm that has, and they come up with a score that's called Hypertension Prediction Index, or HPI. And that basically predicts over the next 5, 10, 15 minutes, how likely are you to experience an episode of hypertension in your patient? And based on that, what is the most likely intervention that will mitigate that episode, whether it's fluid or vasopressors or otherwise.
So when you say goal-directed therapy, it's a little bit in contrast with what we've traditionally thought of with sort of oxygen delivery goals or maximizing stroke volume. This is specifically a blood pressure goal rather than
hemodynamic goals.
Yeah. And HPI is the trigger for looking at cardiac output, stroke volume, and things like that, which is interesting. It was kind of flipping what we had traditionally had. What we also did, though, that was a little bit varied from a traditional GDT protocol where you fluid challenge at the beginning. We just gave everybody about a liter of fluid before and during induction. So we already kind of did that. And then we were looking at where their HPI was. And for anyone familiar with the Edwards product, HPI, it's an index 0 to 100, and the alarms are for an HPI of 85. Well, if you're seeing an HPI of 85, you're almost hypotensive. I mean, it's right there. You're going to hit the wall. What we did was pull that way back to an HPI of 50, and that was our trigger. Then we started to look at, okay, what are our issues? Do we need an inotrope? Is it a flow issue? Do we need more volume? And I think it was really interesting for everyone who was participating in this, and eye-opening, because traditionally we have fluid restricted. Our inotrope ephedrine has been locked up because it's a scheduled drug. And so we really only had vasopressor, and we used neosynephrine. And we were able to reduce our use of neosynephrine significantly. I think we reduced it by almost 72%.
What's that drug in English?
Neosynephrine? Phenylephrine. I'm sorry. I thought I was using it right. I went, oh my gosh.
No, it's good to know.
Yeah, phenylephrine things.
and I'm interested because we're going to come back to a discussion later today about the sip-till send and fasting times. What for this group of patients? So these spines, are they generally fasted for quite a long period of time? Are they drinking up to 2 hours before? What's the context that you're giving a liter in that introductory period?
Yeah, if we're giving a liter, it's giving it through intravenous. Some of them were MPO after midnight. Some do drink up until that time. There's a little bit of variation in our ERS protocols and things like that. I would say it's not necessarily consistent that everyone was coming to us completely hydrated because their MPO time was 2 hours.
And I think one of the takeaways from work like this is, as a general population of clinicians, the default mode is to be NPO after midnight. And that doesn't always work best for everybody. And whether you utilize advanced technologies or not, at least this just gives you a hint that it's not always the vasopressor that's going to save you. Even if it shows you a better number on a monitor, that might be causing acute kidney injury afterwards. So sometimes you have to, most of the time I would say, you have to really consider multiple options before you treat an episode of hypotension or an expected episode of hypotension. It's just something for the clinicians to take into consideration.
Yeah. Well, lots more to come on this. I'm sure we're going to continue to talk about it. It's a passion project for both of us, and working closely, with Leatherman Spine has been really kind of a great collaboration. We've learned a lot.
That's great work. It's really good to hear it progressing year on year, and it's getting into intervention stage, and you've got publications coming through this.
Absolutely.
Congratulations.
Now, while you wear, just really quickly as we wrap up here, you wear so many different hats. One is, strictly working with Wayne State and at your institution, doing some really novel approaches to research. So just really quickly, we caught up with you at IARS back in the spring, the International Anesthesia Research Society. So tell us just really quickly about how things are going for you in that space.
So to separate the hats, the NorthStar hat is what we've talked about. I have my academic research hat, which is through Wayne State and Michigan State and my hospital. I have my own private hat that I'm trying to design myself. I run a couple of projects that are really near and dear to my heart, looking mostly at the human aspect of medicine. So whether it's clinicians or patients, and I'm trying to highlight some of the things that we do every day and how they impact us in ways that we don't quantify. So on a private, whenever I have a little bit of time, which doesn't happen quite often, this work is going through a company called Ether Innovations, and I'm trying to get perspectives of clinicians and patients to things that we do on a day-to-day basis. So for example, one of the projects that we're wrapping up right now is looking at how patients perceive us doing all this monitoring and all this data that we collect, and they never hear back and they don't know what we're doing. They just say, oh, I have 5 different monitors on me. I don't know what they do. A lot of patients don't understand the value of that, and some patients actually want to learn more about what we're doing. So I couldn't find a whole lot of data out there that quantifies what patients want, what they think. Do they think it's too invasive? Do they think they want more? Is this going to help them be more proactive in their own taking care of themselves? So that's coming soon. Be on the lookout for that. The other one is trying to also humanize clinicians with all the talk about burnout and moral injury and all of those things. Same thing. I've had a lot of collaborations with wonderful partners, and we're trying to highlight how clinicians can be taken care of a little bit better, and how we can approach this whole relationship between clinicians and patients and administrators and all of that It doesn't have to be a war. We don't have to all be fighting each other. It's just there's a lot more to be done there. There's multiple groups out there who have the same interest, and we're trying to collaborate.
Trying to create a more nurturing professional environment.
Yes, because a lot of people feel that medicine has become too much of a business, and it doesn't have to be that way. I think most people went into medicine with a calling, and they have a passion for it. And it's a shame to see people burning out and leaving medicine just because of that.
Yeah.
That's unfortunate, but I think there's something that we can do about it.
Fantastic.
Great work.
Yeah, absolutely. Wow, always wonderful to catch up with you here on
Absolutely.
TopMedTalk. I love
Thank you.
always hearing about all the cool projects that you're doing and really, truly moving the needle and pushing NorthStar in a great direction, but also, just professionally within the world of anesthesia. It's amazing work.
We do what we can.
Yeah, that's all right.
Thank you for having me.
Yeah, absolutely. And thank you for listening to TopMedTalk here at Anesthesiology 2024. Be on the lookout for more conversations, outstanding guests that we have lined up for you over the weekend. You can find us on social media. We're on X, which is formerly known as Twitter, LinkedIn, Facebook, also YouTube. If you catch us on YouTube, give us a little thumbs up. Leave a comment. We love all of that. We're really trying to push YouTube a little bit more. So do help us out there. And again, thank you to the ASA for having us here. So thanks, everybody. We'll see you soon. Cheers.
See you later.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.